Diseases of the heart are a frequent cause of dyspnea. Especially heart failure has become a global burden. It affects over 23 million people worldwide. Even worse, we expect to see more patients with heart failure in the future. Why? Our population is aging, and heart failure is a condition that is very common in the elderly. It is quite clear the diagnosis of heart failure should be made as soon as possible while patients are in the early stage of disease. Early initiation of treatment not only improves symptoms and exercise capacity, but also the prognosis of our patients. Ultrasound plays an important role as a frontline diagnostic tool. Observing the contraction of the heart easily allows you to diagnose heart failure in many patients. As a matter of fact, ultrasound is more sensitive and specific compared to the physical exam, the ECG, and even the chest X-ray. So ultrasound is important in patients who have symptoms of cardiac disease, but also in asymptomatic patients where physical findings, the ECG or the chest X-ray, indicates a problem of the heart. In the following lecture, Professor Thomas Binder from the Medical University of Vienna, Department of Cardiology, will explain how ultrasound can be applied in a primary care setting. Here you will learn to image the heart and estimate left ventricular function. In addition, we will show you how to detect a pericardial effusion, another important condition that needs your medical attention.
Do you see the difference between these two echocardiograms? Yes, obviously. Here on the left-hand side, we have a patient who has very poor cardiac function, and on the right, we have a patient who has normal function. So you see, it's not very difficult to tell if a patient has a problem of the heart. Here is another image, again of the heart, but this time from a slightly different position. There's a difference between these two images as well. We have pericardial effusion here, while this patient does not have pericardial effusion. Again, very simple to detect with ultrasound. But before we go on, we need to talk a little bit more about the symptom of dyspnea, a symptom which is very common. There are obviously many diseases which can cause dyspnea, but the organ systems which are most frequently involved are the heart and the lung. As a matter of fact, 42% of all causes of dyspnea are in some way related either to the chest wall, the pleura, or the lung. And 19% are related to the heart. And frequently you will have problems both of the lung and the heart, 9%. So putting this together, basically, if you cover the heart and the lung, then you will probably detect 70% of all causes of dyspnea. Now turning to the heart, what are some of the causes of dyspnea related to pathologies of the heart? Well, you see some of these pathologies are quite frequent, such as coronary artery disease, hypertension, valvular heart disease, tachyarrhythmias, for example, atrial fibrillation, and pericardial effusion. You will encounter many of these problems in your daily clinical practice, and the heart therefore plays a central role when it comes to diagnosing or detecting the cause of dyspnea. Now, the good news is we can detect many of these pathologies highlighted in red with the help of handheld ultrasound. We're going to cover some of these topics in this lecture. But what about the physical exam? How helpful is it really in detecting patients with heart failure? The sobering fact is it's not very good. It has a sensitivity of only 10%. Maybe you might be able to detect forms which are more severe with a higher sensitivity, but in the overall population, these are the facts. Even if you take all the findings together, RALs at pulmonary auscultation, jugular distension, lower limb edema, ventricular gallop or tachycardia. Now, I'm not saying you should not perform a physical exam. It will be complementary, but with the help of ultrasound, you'll be much quicker and you'll get much more out of the exam. And how good is the physical exam if you want to detect a pericardial effusion? Even worse. Don't forget that 37% of patients actually don't have any signs or symptoms that are indicative of a pericardial effusion. Here, ultrasound will be extremely important. So what is the bottom line? Ultrasound is slowly moving to the forefront of diagnostics, and it is complementary to the physical exam. But let's hear some of the statements from key experts who've been using ultrasound for many years.
Think about the stethoscope, auscultation. That is highly subjective. Do you hear the murmur? What's the grade of the murmur? Do you hear these crackles, yes or no? But when you have an image, a picture is worth 1,000 words.
If you have a handheld device, I think it's even more useful than using a stethoscope. Within seconds, it tells you exactly if there's something wrong with the heart, if there's something wrong with the valves, and you get a pretty good overview about the function of the heart.
I do think that a general practitioner can learn to assess left ventricular function, at least in a way that will give him some basic information and tell him if there is something major going wrong.
If you have such an ultrasound probe, you don't need stethoscope any longer because ultrasound is the modern stethoscope.
Let me again come back to the physical signs during the exam. Now, it's very important to look at these as well because they can be indicative that the patient truly has a cardiac or, as you will see later, pulmonic problem. So watch out for these. The truth is that in these situations, you will have a higher yield. You will more frequently find a pathology. The same also holds true for the history of the patient and the symptoms. So some of the symptoms which are related to heart failure and to problems of the lung are also outlined right here. When you image the heart, it's very important to understand where it actually lies within the chest. Parts of the heart are hidden behind the sternum, the ribs, and the lung. All of these structures are barriers to ultrasound, so we'll be using specific windows. If you point the ultrasound to the heart, the first structure you will see is the right ventricle because it lies ventral. Lateral is the left ventricle with the apex pointing lateral, but sometimes also almost towards the back. So the position of the apex can vary greatly. Below the heart is the diaphragm and the liver. These structures border the right ventricle and the inferior parts of the left ventricle. If we look at the heart in more detail, we will see the base of the heart right here. This is the cranial portion. Here the great vessels enter and leave. Here would be the mid portion, and this is the apical portion of the heart. If we now open up the chambers, we will see that the apex is actually formed by the left ventricle, at least in normal, healthy individuals. The interventricular septum is a very prominent structure. The wall of the right ventricle is not nearly as thick as that of the left ventricle. In this view, you can actually see the left ventricle, the right ventricle, the left atrium, and the right atrium. We're going to show you a view which mimics exactly this display here on the model. In addition, we're going to show you a view where we cut through the ventricles right here, perpendicular to the interventricular septum, displaying the left ventricle and the right ventricle. These are the windows from which we can see the heart. We're going to focus on the three most important ones: the left parasternal window, the apical window, and the subcostal window. In each of these windows, we're going to show you those views which are best suited to look at left ventricular function. In the parasternal window, you're going to image from the left of the sternum, somewhere between the second and the fourth intercostal space. So you'll be imaging from in between the ribs. Here we will show you a view where you transect the heart somewhere here in the middle portion of the ventricle. Depending on how high or how low on the ventricle you're transecting the heart, you'll get an image that looks slightly different. But in both situations, the left ventricle will be a round structure surrounded by the right ventricle in the region of the interventricular septum. The apical window is located at the apex, and from here you will image upwards towards the base of the heart and transect the heart so that you see the four chambers I described previously: the left ventricle, the right ventricle, the left atrium, and the right atrium, with the AV valves, the tricuspid valve, and the mitral valve in between. Finally, the subcostal window, right underneath the xiphoid. You will be imaging towards the left and upwards so that you transect the right ventricle as the first structure. This is a view that looks very much to the four-chamber view we saw previously, only that the right ventricle is now in the near field while the left ventricle is more distal. But you will also be able to see the atria, the right atrium and the left atrium. Before you start imaging, the first thing you have to adjust is the setting. We need the cardiac program. Now, this specific device has two transducers in one. One is the linear probe, and the other one is the phased array probe. We'll be using the phased array probe. In principle, when we image, we have two different positions from where we can image the patient. One is from the right side, and the other is from the left. From the right side, you'll be using the right hand to image and the left hand for the device. If you image from the other side, you would be using the left hand and the right hand for the transducer. Now, I personally have been trained actually to image with my right hand, so that's what I'm going to do. Now, in principle, when you image, the very first thing you have to do is you have to position the patient so that you can get a very good image. And you have to position the patient extremely on his left side, especially if you image from the peristernal window. So that's what we're going to do. Can you turn to your left? The left hand should be above the head, and the right hand should be closely attached to the chest. Then we need some gel. Very important, you have a marker on the transducer. You can see it here very nicely. Put your index finger on this marker and point the marker towards the left shoulder if you want to get a short axis view. I would now sit behind the patient, put the transducer somewhere in the second or third intercostal space to the left of the sternum. I then place the transducer and point it to the shoulder. And here I would get an image of the left ventricle. First, I would adjust the image. I'll probably increase the gain a little bit here. And I try to see that the ventricle is truly round. Now, in principle, when you image, what you can do is you can move the transducer to the left and to the right. You see what happens. You can kind of bring the image more into the middle by doing this. But you can also tilt the transducer. If I tilt upwards, I would see the basal structures of the heart, in this case, the aortic valve, and also the left atrium. If I tilt the transducer down, I would again come to the position that we originally had. But if I tilt even further towards the apex, I would eventually actually lose the image. So the optimal position to look at the left ventricle would be this. Now let's take a look at what happens if I actually rotate. If I rotate clockwise, you see that the ventricle all of a sudden is not round anymore, but it's kind of oval shaped. If I tilt the transducer in the other direction, it is also oval, but it looks a little bit different. It kind of opens more to the left side of the screen. It's also very important that you find the right intercostal space. If I move the transducer further down, you will see what happens with the ventricle. It gets more oval. Now, even though you can assess left ventricle function here, it's probably better to find a view where the ventricle is truly round. So try to stay as cranial as possible. In summary, try to optimize the view with respect to the tilt, the rotation, and the position of the transducer. Let us now identify the structures you can see in this view. We have the right ventricle, the left ventricle, and the structure in between is the interventricular septum. Note that the endocardium is a little bit brighter than the myocardium itself, and the brightest part of the image is actually the pericardium. If you tilt the transducer a little bit more cranial, you will see more of the mitral valve. Note that the mitral valve opens and closes like a fish mouth. Next, I will show you the apical four-chamber view. If you image from the apical four-chamber view, you'll position the patient also in the left lateral position, but a little bit more on his back. You'll be using, again, the index finger on the marker, but this time the marker will be pointing lateral and will be imaging upwards towards the head, actually almost to the right shoulder. Very important, we have to first locate the apex. You can get a little bit of a better feeling if you actually try to palpate where the apex is. And especially in young and slim individuals, you can feel where the apex is. In obese patients or in patients who have some thorax abnormality, the apex can be located very differently though. It can be more lateral or sometimes even pointing to the back. So you have to look for the position of the apex, but you can also do that with your transducer. So I'll use some gel here. Sit behind the patient, place the transducer at the apex, image upwards, and look for the heart. Now, you have to see the ventricle in your field of view. Play around a little bit, maybe a little bit more lateral or further down caudal, so that you see the ventricle in its full length. This would be a very nice view of all the 4 chambers: left ventricle, left atrium, and right atrium. Of course, you can turn and tilt the transducer as well to optimize your image. Look what happens if I rotate counterclockwise. All of a sudden, the right ventricle will vanish. You don't want to have that view. If you move the transducer up, you will get a ventricle which is a lot shorter. But whatever view you get, it's just important that you see the left ventricle, because that's all you need to estimate left ventricular function. What are some of the structures we can see in this view? The left ventricle with the papillary muscle. This is the interventricular septum right here. The left atrium. The mitral valve, you can see that there is an anterior leaflet which is longer and a posterior leaflet which is shorter. Here is the interatrial septum. Now we're focusing more on the right ventricle with the trabeculation, the tricuspid valve, and the right atrium. The last imaging window I will show you is the subcostal window. To image from a subcostal position, you will have to position the patient on his back. Now, the heart is located right here. So when you image from underneath the xiphoid, you will have to image more towards the left. But remember, the heart is also positioned relatively ventral in the mediastinum, so you have to be relatively shallow. A problem sometimes is that patients, especially if they're athletic, have very tense abdominal muscles. You can help yourself by letting the patient raise his legs a little bit like this. This will relieve the abdominal muscles and it will be easier for you to image. Again, we have to put the index finger here on the marker and put this marker towards the side, lateral. Since we want to image very shallow, it's advisable to hold the transducer actually like this from the top. Again, we'll use some gel. In this case, I prefer to actually put it directly on the patient. I'll use a lot of gel because you need to also slide the transducer a little bit, as I will show you. Then I place the transducer underneath the xiphoid and then move the transducer towards the left side. I'll increase the gain a little bit here. While I do this, I let the patient inhale. Hold your breath. And while he holds the breath, you can nicely see a view which looks very similar to the 4-chamber view from the apical position. Only that you have the left ventricle now below the right ventricle. Here you can nicely assess left ventricular function. You can move the transducer back and forth a little bit and you'll see different parts of the ventricle. From this view, it'll also be ideal to look at a pericardial effusion. You'll see the pericardial effusion if it were present right here, or sometimes even down here. So this view can be used very nicely for the assessment of ventricular function and pericardial effusions. Which structures can we actually identify? The first organ that we're hitting with the ultrasound beam, and which is cranial on the sector, is actually the liver. Then comes the right ventricle, the interventricular septum, and the left ventricle. Note again that the pericardium is the most echogenic structure here. We can have a view of the interatrial septum, the mitral valve, and the tricuspid valve. If we move the transducer a little bit more towards the right, we will see more of the liver. And actually at some point, if we tilt a little bit, we'll see the inferior vena cava as it enters the right atrium. But for the assessment of ventricular function and pericardial effusions, the most important orientation is that, again, towards the left, where you see the left ventricle and the right ventricle in your field of view. Some final tips. If you want to improve your image quality, press the transducer firmly on the chest. You have to indent the transducer at least to some degree because you want to have a good contact with the body. Next, rest your arm on the chest of the patient because there you are more stable. Use enough gel. Use
the respiration to your advantage. Sometimes you'll get better image quality if you let the patient inhale, sometimes when he exhales. Try both. But most important, practice. Because only with practice can you get better, and eventually you'll be more confident.
Of course, you will need to practice to get good images. But I want to show you some very important and valuable tips and tricks that will make life easier. First of all, use the correct depth. Why is that important? Well, because you want to have the entire ventricle in the field of view. Here's an example where the depth is set too high. You have much of the surrounding structures, but not the heart in the center and in the middle of the image. Orient the probe to the ventricle that you want to see. If you want to see the right ventricle, you're going to point the transducer more to the right. If you want to see the left ventricle, point it to the left. If the ventricle is not in the center of the image, you can slide the transducer back and forth. In this situation, the lung is kind of overlapping the ventricle. So you need to slide the transducer more towards the sternum, and then you will get a view which looks like this. Now you can really appreciate all the different segments of the left ventricle. What about rotation? It's equally important. If you either over or under rotate, the ventricle will be open either to the one or to the other side. So all you need to do is correct either clockwise or counterclockwise. And don't forget, position the patient correctly. In such a situation, you can often get much better image quality. Here is what happens if you place the transducer too far caudal. In this situation, you will get a ventricle which is oval in shape. In other words, it looks like an egg. This would be one intercostal higher, where the ventricle now has a round shape. Now, I'm not saying that you cannot look at ventricular function in such a view, but usually the image quality will be better if you move up one intercostal space. The tilt is important. If you tilt the transducer from a short axis view more towards the base of the heart, so more cranially, you will see the great vessels, in this case the aortic valve. Now this is a standard view in echocardiography, but if you want to look at the ventricle, this is not the correct view. You need to tilt the transducer more caudally. Here would be an intermediate view where you're actually looking at the level of the mitral valve. This structure here, which opens like a fish mouth, is the mitral valve. Here, you should not look at left ventricular function. Rather, you should tilt more caudally so that you get a ventricle which looks like this, where you do not see the entire mitral valve in your field of view. Here are some facts about heart failure. Now, heart failure is a very frequent condition. It occurs in 2% of the adult population. And it's extremely common in the elderly patient population, with over 8% of over 75-year-olds which actually have heart failure. As a matter of fact, it's more common than most cancers. It's a disease which has a poor prognosis. Nearly 40% of patients with congestive heart failure will die within 1 year of first hospitalization. Echo plays a very important role because many patients are asymptomatic, and if you perform echocardiography, you will detect these patients in a very early stage. And that is important because we have treatments available, and these treatments are highly effective and definitely change the prognosis of the patients. What are some of the causes of heart failure? Which cardiac conditions can cause deterioration of left ventricular function? Of course, coronary artery disease. Here, patients develop infarcts, where ventricular function is poor and where congestion and signs of heart failure might appear. Hypertensive heart disease. The problem here is that the ventricle has to cope with a higher pressure, and therefore he develops left ventricular hypertrophy and eventually also heart failure. Dilated cardiomyopathy. Patients might have viral infection of the heart causing myocarditis. Maybe they have a genetic form or some autoimmune cause of dilated cardiomyopathy. In any case, these patients can present at a rather young age and develop heart failure, sometimes even severe forms, which necessitate advanced treatments, maybe even transplantation. Valvular heart disease. Both regurgitation and stenotic lesions can lead to heart failure. Very common is aortic stenosis. But we also see patients with severe mitral regurgitation or aortic regurgitation, which over time develop heart failure. Let's not forget that there's a number of different cofactors which are associated with heart failure. Up front, we have to mention diabetes. Here are some statements from key experts on how primary care ultrasound can help in the diagnosis and in the management of heart failure.
You can have a look at the heart and see if it's big or if it's not big, and you can see how the ventricle is contracting. That's the one thing. The other is it's very easy to detect pleural effusion because this takes 5 seconds.
Just recently I saw a patient in the office with dyspnea. She had no physical signs of heart failure, but I used ultrasound. And so I saw an extremely reduced left ventricular function, and the diagnosis was clear.
Basically, a pericardial effusion results of an imbalance between the amount of fluid that is produced within the pericardial sac and the amount that is resorbed, or if some structural abnormality is present where often blood enters the pericardial sac. What are some of the most frequent causes of a pericardial effusion? Pericarditis, for example, caused by some bacterial infection. But you also see it in viral infection. For example, in myocarditis, where the pericardium is often involved in the infectious process. Autoimmune diseases, for example, sclerodermia, lupus, and many, many others. In renal failure, hemodialysis patients frequently have at least some degree of pericardial effusion. And cancer. But be aware that in many instances we do not know why patients actually have a pericardial effusion. Often it vanishes over time. Be aware that many patients do not have any symptoms at all, especially if a pericardial effusion is small. Still, some patients have chest pain, maybe even arrhythmias, dyspnea. If patients have low blood pressure or if they are in shock, we consider this as tamponade. In such a situation, the pericardial effusion is causing some form of hemodynamic compromise. Always be on the lookout for a pericardial effusion in patients who have cancer. We know from autopsy studies that 20% of patients with cancer actually have a pericardial effusion, especially if patients have lung adenocarcinomas, breast cancer, or gastric adenocarcinomas, or esophageal tumors. With primary care ultrasound, it's quite simple to detect a pericardial effusion, especially because it is frequently located in the region where the diaphragma borders to the pericardium. Here you have a beautiful example where such a pericardial effusion is present, and we see this as an echolucent zone within the pericardial sac. Compare this image here to this image here. There's definitely no free space between the liver and the pericardium. Of course, the size of a pericardial effusion can vary greatly. Here's an example of a patient who has a rather large pericardial effusion. Look how broad the echo-free space here is. And we can actually measure the size of a pericardial effusion. We do this at the moment when the heart is largest, in other words, during diastole. Here you see such a measurement that was performed. Now, a pericardial effusion can also be seen in other views, especially if it is large or if it is circumferential. This is a 4-chamber view where you see the pericardial effusion here lateral to the left ventricle. This is the short axis view where we see the pericardial effusion inferior. Note that this again is the pericardium here, and below the pericardium we have the diaphragm. So pericardial effusions can be seen in multiple views, but the subcostal view is usually the preferred view where you should be looking for a pericardial effusion. This is an 81-year-old patient who comes to your office with a long-standing history of hypertensive heart disease. He comes because he has dyspnea, and these are his images. Here we have the 4-chamber view, and as you immediately can recognize, global left ventricular function is significantly reduced. Note that the ventricle is also dilated, and note that the myocardium is rather thick.
Now, this is not to a surprise because after all, the patient has hypertensive heart disease, and this is how the ventricle reacts with hypertrophy. You see pretty much the same thing here in the subcostal view, a dilated left ventricle with significant hypertrophy. Now, the diagnosis is clear. He has heart failure because he has long-standing hypertension. Of course, this patient needs further attention and further treatment. Here's an 83-year-old woman who comes with a history of hypertension, and she complains of a drop in exercise capacity. You perform an echocardiogram. Here is the 4-chamber view, and you will immediately recognize that left ventricle function is not only normal, but even hyperdynamic. You see how vigorously this ventricle is actually contracting. You see the same thing here also in the short axis view. Note that the thickness of the septum is increased. This is again hypertrophy. In other words, this patient has hypertensive heart disease. But one thing is for sure, she probably does not have heart failure as a cause of her symptoms. Of course, she needs further attention, and of course, you will rule out some other pathologies of the heart that this patient could have. A 28-year-old comes to your office and complains of shortness of breath. He's kind of worried because his father just recently died because he had coronary artery disease and heart failure. Now he had symptoms of a flu and is worried that he has myocarditis and heart failure as well. So you perform an echocardiogram, and what can you tell the patient immediately? Well, let's take a look at the loops first. Here is the short axis view. You see normal contraction, and you also do not see any echo-free space. In other words, the patient does not have pericardial effusion. The same is true here in the 4-chamber view. The ventricle is contracting quite nicely. And in the subcostal view, you also do not see a pericardial effusion. So basically, there is no evidence that the patient truly has myocarditis or heart failure. Of course, you cannot rule it out 100%, but if all the other findings are negative, he simply does not have myocarditis. You perform a routine medical checkup in a 64-year-old. You do hear a systolic murmur. Now you perform an echocardiogram, and this is the 4-chamber view that you see. Now this might not be so evident, but left ventricle function is not normal in this case. Now, of course, it does not explain the systolic murmur by itself, but this is an example of a patient who needs further attention. She could have some form of regurgitation. We cannot tell simply by the 2D image. So be aware that there will be some ambiguous situations, but at least you will find those patients who need further attention where you then could perform a more thorough exam or refer the patient to a specialized center. Now, when you image the heart, you cannot avoid to see other findings as well. I just briefly want to go through some examples that highlight the large spectrum of things that you might pick up. Here, for example, is a patient who has a mitral valve prosthesis. You can clearly see that there's a lot of shadowing here in this region. This is where the mitral valve is. Here is a patient with a very dramatic finding. Lots of thrombi here in the ventricle. Here and here as well. There's another thrombus even in the atrium here. A very frequent finding, especially in the elderly, is what we call mitral annular calcification. Here is this finding. You see a bright echogenic region, usually in the region of the posterior leaflet, in other words, here at the lateral part of the ventricle. Frequently, you will even see a shadow, similar to what you see if you image a gallstone. In elderly patients, you can also see papillary muscle fibrosis. This is such an example. You see that the papillary muscle here is also very bright, or at least the tip is very bright. This is a sign of aging, nothing more. It's even possible to see pacemaker leads in echocardiography. So be aware, they represent themselves as longitudinal structures, also frequently with artifacts and with reverberations. This is a patient who has a mitral valve prolapse. You can see that the mitral valve is very bright and thickened and prolapses or protrudes into the left atrium. In addition, in this patient, you also see that the function is hyperdynamic. This is frequently the cause in patients who have severe mitral regurgitation. This patient had severe mitral regurgitation because he had mitral valve prolapse.
Let's summarize some of the things we learned in this module. First of all, dyspnea is very common, and it's often associated with a disease of the heart. Primary care ultrasound is an ideal technology to look for the cause of dyspnea. You can really make a difference if you're able to detect heart failure at an early stage. The views which are best suited to look for left ventricular function is the parasternal short axis view from the parasternal window, the apical four-chamber view from the apical window, and the subcostal four-chamber view where we image from the xiphoid up towards the heart. This view is also very important when you want to look for a pericardial effusion.